Hello and welcome to Riverside's Heart Month lecture series. In honor of Heart Month, Riverside is excited to be presenting a new community lecture on a different cardiovascular topic each Thursday this month. Today, we will be focusing on arrhythmias, or specifically the treatment of atrial fibrillation. We have three specialists with us tonight from Riverside Cardiology Specialists. Dr. Scott Kaufman, Dr. Jamshid Alaeddini, and nurse practitioner Kim Liebold are joining us to talk about what a diagnosis with atrial fibrillation, or Afib, means, the ramifications of that diagnosis, and the various treatment approaches that are available. I'm sure there will be a lot of information covered, but the beauty of video is you can rewind and listen again if you want to rehear any part. With all that in mind, let's get up to tonight's presentation. And without further ado, I will turn it over to Kim Liebold.
Hi, thank you for joining us tonight. And we are just very excited that we're able to come to you at your home. So we ask you to just kind of sit back for the next 30, 40 minutes, maybe have a heart healthy snack, a bottle of water, and you might have a piece of paper and a notepad. You might find some questions or some statements that would help you. And certainly this is information that when you go to see your provider, you may want to share with them. Our concept in our conversation tonight is going to be on atrial fibrillation, because that is a heart rhythm that is very common and many people have it. And I'm sure those who are listening to us either have atrial fib or certainly know somebody in their family or friends that do have it. So we're going to concentrate on that. And I will be starting off talking about what it is and how we classify it and diagnose it. And then I will turn it over to our electrophysiologists, which are cardiologists that are specialized in heart rhythm issues. I like to call them our heart electricians. And they will go through, Dr. Alaeddini will go through the treatment options, as there are many treatments. And I think a very big take-home message for this is there are thousands and thousands of people out there who have atrial fibrillation. And everyone is very different. Just because someone has something that's more symptomatic and life-altering for them doesn't mean theirs is more serious than somebody who has no symptoms and doesn't know about it. So it is a very prominent thing that people have, and each treatment is based on that person's health, how they feel with it, and how their overall quality of life is. So it's very important to have an individualized plan of care. And that's why it's important to go to your doctors and work with them and find out what works for you. Because a lot of times when we are diagnosed with atrial fib, we go with one strategy and it works for a while, and maybe it doesn't work again, and you need to change a different focus. Or sometimes there are options, as Dr. Alaeddini will talk about, that are like ablation procedures that sometimes are better done early in your diagnosis at a young age. You're much more likely to have success with them than if you wait long periods of time and the heart gets used to being an atrial fib. So the key is knowing what this is, getting diagnosed as soon as we find it, and then working towards with your providers for that treatment option. As we talk about some of the different treatment options, Dr. Kaufman also will join us at the very end and talk about the high risk of stroke with atrial fibrillation, and then different strategies and things that we can do to prevent that. All of the different therapies and strategies that we talk about and procedures are done here at Riverside Regional, and both Dr. Alaeddini and Kaufman do all the procedures we talk about. So between ablations and left atrial appendage or Watchman, or some of the pacemakers, and particularly the new Micro, which is a small leadless pacemaker, are all things that we do here at Riverside Regional, and both doctors do. So I'm going to go ahead and start us off just to kind of explain. This is our Riverside Ready team, which shows all the different wonderful places that we get to work here at Riverside. And we just have an amazing, awesome team between the OR and the cath lab and our office and arrhythmia department. And we're very fortunate. So to start off, to know what is abnormal, you have to kind of understand what is normal first. And I'm going to talk about the electrical conduction system, but this short video may be a little bit more technical, but it'll kind of show you the visualization of it. And so our electrical conduction system is basically where the heart, the top chamber of the heart, has its own natural pacemaker that generates the electrical activity and sends a signal from the top chamber of the heart to the mid station, which is called the AV node. And then it goes down simultaneously into the bottom chambers of the ventricle, where it then stimulates the heart to beat. So you have this very symmetrical, timed rhythm of the heart that we are all in, we take for granted and don't really know about it. But I want you to watch the functioning of the heart, how it nicely fills and squeezes and then blood flow goes out. And when we talk about atrial fibrillation and how it's different, you'll understand where some of the symptoms come from. So I'm just going to play this really quickly for us.
Action potentials originate in the sinoatrial node and travel across the wall of the atrium from the sinoatrial node to the atrioventricular node. Action potentials pass slowly through the atrioventricular node to give the atria time to contract. They then pass rapidly along the atrioventricular bundle, which extends from the atrioventricular node through the fibrous skeleton into the interventricular septum. The atrioventricular bundle divides into right and left bundle branches, and action potentials descend rapidly to the apex of each ventricle along the bundle branches. Action potentials are carried by the Purkinje fibers from the bundle branches to the ventricular walls. The rapid conduction from the atrioventricular bundle to the ends of the Purkinje fibers allows the ventricular muscle cells to contract in unison, providing a strong contraction.
So we just kind of seen what the normal electrical conduction system, and that's called normal sinus rhythm. That's what we're all in. And when we talk about atrial fibrillation, we talk about strategies to get you back into regular rhythm. That's what we're referring to. But what is atrial fib? We also call it AF or AFib. You'll hear different things referred to, and it's an abnormal heart rhythm, or we call that an arrhythmia or dysrhythmia, when the heart does not beat in a steady rhythm. Atrial fib occurs when the upper chambers of the heart or the atria fibrillate or quiver, causing a fast or rapid irregular heartbeat. It is the most common type of arrhythmia. 2.3 million people in the US have AFib, and 160,000 new cases are diagnosed every year. So approximately 9 out of every 100 people over the age of 65 have AFib. So that's why it's the number one thing we're consulted for, and we see patients and have a lot of strategy options to help because it is so prominent and seen. So again, what exactly is atrial fib? It's a rapid, erratic firing of many different cells or groups of cells in the top chamber of the heart. And this erratic behavior prevents the organized electrical signals from coming down and going through the normal conduction pathway. This results in the quivering of the atria, no real squeeze, and reducing the cardiac output. And that's a fancy way of kind of saying that normal, if you remember the video where the electrical current kind of came through and traveled through the heart in a very organized way, now we have all this chaotic kind of movement up in the top chamber. And I tell people that it's almost like the top chamber of the heart is like a bag of worms or jello, and it just quivers, and the bottom chamber is trying to see all these impulses coming down and trying to respond to each one like it's supposed to, and it comes off with a very irregular heart rate and often a very fast one. So this is kind of just showing you the little chaotic activity of electrical impulses, and it overrides the normal conduction system so that your normal pathway can't take over. So in an electrocardiogram or a EKG tracing, this would be like a strip that you see if you were in a hospital and being monitored, or a part of an EKG. This bottom chamber is showing you regular rhythm. So what I want you to focus is each of these tall spikes are equivalent to a pulse or a heartbeat. And so you can kind of see that this is a very regular interval or a very timed thing. And so that heart rate is about 60 beats per minute, and that's normal. If you look at the top tracing, that is atrial fibrillation, and you can just see the differences of it by looking at the space between these tall spikes. It's very irregular. Some are longer, some are shorter, and it's much faster than what's down here. This is probably about 80 beats per minute, and it varies quite a bit. People in AFib try to check their heart rate, and it'll be 80 to 90 and 100 very, very easily. So that's that concept of what the EKG looks like. This, I believe, will be a short little video that doesn't have any sound. I'll talk through it, but it just shows the heart contracting in atrial fib. So you can see that's a normal heartbeat, and you can see how it just kind of nicely squeezes and visualize the top and the bottom kind of work together as a team. In atrial fibrillation, the top is quivering, the bottom's trying to figure what the heck is going on, and so you get this dyssynchrony or dysfunction. and again, normal beats when we get to restore it. So that kind of helps you see why people do better in regular rhythm for the most part. And then there are those people who don't feel it at all and have no symptoms. And I think it's important for the people listening, because many of you may have AFib and live with it. That is absolutely acceptable and often done when people have it and live long term with it, because it doesn't bother them. They're protected from a stroke with a blood thinner. Their rate is controlled with medications, and they live absolutely fine, quality of life, no issue. There are other people, and we'll talk about it, that don't have those kind of same outcomes and need different therapies. So who is at risk for developing AFib? When we go through this list, you'll see why it's so common, because everything can really contribute to atrial fib. Greater than the age of 60, high blood pressure, coronary artery disease, prior heart attacks, congestive heart failure, structural heart disease with valve problems, or congenital, those you're born with, defects. Previous open heart surgery, untreated atrial flutter, another type of abnormal heart rhythm that Dr. Alaeddini will discuss. Diabetes, thyroid disease, chronic lung disease, spleen apnea, excessive alcohol or stimulant usage, serious illness or infection when the body's just really stressed from some type of illness. We see it a lot with the COVID and different things that are going on in our world today. Blood clots in the lungs, also known as PE or pulmonary embolus. And here's the bottom line: healthy lifestyle with no other medical problems can develop AFib. So you can do everything just right and be an elite athlete that runs and does things and have AFib. So it really is non-discriminating. The symptoms of atrial fibrillation, again, are very unique to each person. We tend to find that once you kind of have that, you tend to be symptomatic if you start off your journey with AFib that way. Fatigue, tiredness, decreased exercise capacity, just can't quite do the things that you normally do without stopping and resting. Heart rate that's faster or irregular than normal, shortness of breath, heart palpitations, chest pain, pressure, tightness, or discomfort, dizziness, lightheadedness, fainting. And some people have none. There's a large population of people who have no idea they have AFib. It's an incidental finding when you go to your family doctor for your wellness physical, and they listen to your heart tones and hear the irregularity and get an EKG and find you're in AFib. You come into the hospital for a procedure or a surgery, and they do a preoperative EKG, and you found to have AFib, and your surgery is held off until you can get the AFib treated. Another unfortunate is a symptom is a cryptogenic stroke. And that's unfortunately a stroke that occurs that has really no cause at the time. They can't figure out what it is. And the workup for that we'll talk about comes to find out that the person had AFib and never knew about it. So there is a large population that just don't know that they have it. So how is it diagnosed? We talked about that. Off of an EKG, most likely, is the most common thing, or rhythm strip. We also can find it on monitors. If you have these episodes and you think they come every day or once every 2 or 3 days, we can use a Holter monitor where you wear it and you go about your normal activities for up to 3 days. And then we look at that rhythms to see if you have AFib in that. If we can't capture it in that 3-day period, there's different types of mobile cardiac monitoring devices that we use. They're worn for 30 days. We teach you to put them on and take them off so you can shower. The mobile cardiac monitoring has a really nice feature that you can push a button and say, pay attention, I'm having a symptom, and we correlate your symptom with what your heart rhythm is and see if that's causing it. But it also has an auto trigger feature, which is the technology of the monitor, and it's looking for abnormality of these irregularities between the EKG. So when it sees something irregular, it will trigger. If it sees heart rate speed up quickly or drop quickly, it will trigger without you even knowing it or feeling it. And it allows us to capture things that you don't even are even aware of, a lot of times even when sleeping. We also have the intermittent event monitors that we can wear for 14 to 30 days. Some of them are just like patches, like a big Band-Aid that we put over the heart to capture that data as well. The newer technology, and we get this question asked a lot, is how good are these things that you can, as consumers, have that aren't medically prescribed at the time of a visit? They are totally dependent on you and how your tech skills are, which are really pretty good for most of our patients. The Apple Watch is now has a lot of features, and depending on how much you want to spend on it, it can give you tracings that you can have saved in PDF files. And actually, we now work with a lot of our patients to upload those PDF files in your MyChart. They come to us, they have your identifier, your name and your date of birth on them, and usually some type of symptom related topic. And then we have that tracing put into your chart, and we utilize that. There is also another option called a KardioMobile Alive Core app, and that is about $100. So that's a little bit more cost effective. And that is just a small device that you place your fingers on each of these buttons. And then you use any of your smartphones, Android or iPhones or iPad, and that data will come across as an EKG. Again, you store it in a PDF file and can upload it to MyChart, and we can see it. Actually, yesterday in our office, Dr. Alaeddini and I saw a patient, and he uploaded his event on one of these, and we were able to utilize that and diagnose it and treat him based off of it, and did not have to do the event monitoring. So those are the new technologies that we do have and are using. Also is the implantable loop recorder. All of our doctors put these in, and these are small. You can see them down here. They look like a little USB port, a little USB file. And they are placed under the skin, kind of over top of the heart area, and they are good for 3 years. So they record data 24/7 for 3 years, and all of that is provided to us through a secure website through Bluetooth technology, and it comes through, and we see it in the office setting, and you never have to come in the office, but maybe once a year. We do this usually for select patients, those who have syncope or passing out spells, and we can't figure out why. And then this is our new standard of care for cryptogenic strokes, as I mentioned earlier. Those people who have strokes and we don't know the reason for it, they are put on, this is put in under their skin, and we monitor them to see, in fact, did their stroke come from atrial fib? And I can tell you, we have quite a bit of these in our practice, and a lot of people, we find AFib in them from that. It is also diagnosed sometimes when people are getting echoes because they're watching heart rhythms and the way the heart squeezes. Cardiac CTs and cardiac MRIs can also tell us that. So now you've been told what it is and how we find it. So now I'm going to just go really quickly over the classifications, and then Dr. Alaeddini will pick up from there to talk about the treatment strategies. So atrial fibrillation has 3 classifications. It's paroxysmal, persistent, and long-standing persistent, which we used to know as permanent or chronic, and people still call it that a lot of times. So paroxysmal atrial fib is unpredictable. It is a short duration, minutes, hours, or days, and it can stop suddenly without treatment. This is often what people have and don't even know, and it's kind of hard to capture. That's why we need the longer monitors or sometimes the loop recorders to determine that. Persistent atrial fibrillation is lasting longer than a week. It keeps going on until treatment with a medication or procedure comes in and interrupts it and gets it back into regular rhythm. And that's where we see most of our patients, because by the time we get them, you know, they've been defined as having atrial fib. And Dr. Alaeddini's and Dr. Kaufman's talks will talk about, you know, again, the treatment, medications, and procedures that we use to keep you out of atrial fib as much as possible. And then there's the persistent long-standing atrial fib, also again known as permanent or chronic, continues for over a year, does not go away a lot of times with treatment, no matter what we kind of do. And cardioversion, which Dr. Alaeddini will review, which is electrical shock to kind of restart the electrical activity in the normal way. I call it rebooting your computer. That cardioversion is not considered to be helpful or restore the heart. And basically in this situation, these are the people that I was referring to earlier that can live with atrial fib for a long time. They may not be symptomatic. We make sure they're on a blood thinner to reduce their stroke risk. and we put them on some type of medicine to make sure their rate is controlled. And they can do absolutely fine with it and not have any problems. And this is an acceptable option, and you and your provider have that conversation to see if this is the right goal for you. There are people who have enlarged hearts, or that just, we know in the environment of that heart, they're not going to go back into regular rhythm. They've been in AFib too long. The heart is too used to it. And no matter what medicines and procedures we do, they just unfortunately kind of do this. But there are other options, again, to help with symptoms. If you have permanent AFib and have symptoms, there are things we certainly can do to help with that. So the treatment options are going to be rate control. So medications, ablations, device procedures to control the rate. You may be irregular and you may stay in atrial fib, but we control the rate. The other option is rhythm control, and this is where we want to get you back in regular rhythm. We're trying with all of our abilities to maintain that regular rhythm, and those we use the anti-arrhythmic medications, ablation, and a procedure called PACE and ablate, where we put a pacemaker in and do an ablation. And Dr. Alaeddini will go over all of that in detail in just a little bit. And the last is a medicine that we use on both rate control if you're in AFib, or rhythm control if we're trying to keep you in regular rhythm, and that is blood thinners to reduce your stroke risk. And that is Coumadin, or the new, we call them DOACs, which is the direct oral anticoagulants that are the Xarelto Eliquis type medicines. And then if all of that's contraindicated, we do have a new one, an ability to do a procedure called Watchman, or left atrial appendage closure, that Dr. Kaufman will share with us. So the last thing I'm going to touch on just briefly is complications of atrial fib. Again, another big take-home message is this is not life-threatening. AFib is not life-threatening. This is not those rhythms that we deal with in electrophysiology world that cause sudden death or are anything of that nature. But they are have risk for other serious complications to include heart failure and stroke. And so it is important to pay attention to your body, to pay attention to this, and go see your doctors and stay up with them to get it controlled and get it treated, because you can prevent some of these things from happening, or if they happen, we can reverse some of that. Again, the goal is medications to control heart rate and keep the heart rhythm in control if we can, and using blood thinners to reduce stroke risk. One of the common things that sometimes happens with atrial fib is called cardiomyopathy, and that's an enlargement of the heart muscle. And it is often caused from a fast heart rate for long periods of time. So this is when people are in atrial fib and their heart goes really fast. And you think about the heart's a muscle. So when that heart's going really, really fast for long periods of time, we're talking weeks, months, then the heart gets tired and it gets weakened. And when it gets weakened, then you have an increased risk for heart failure. And so again, in that situation, it's very important to do heart rate control or rhythm control. And then stroke is our last thing I want to just touch on, and Dr. Kaufman will go through that more specifically. But people with AFib are 5 times higher risk for AFib, and it doesn't matter if you're in it, paroxysmally, you go in and out, or you're in it all the time, you still are at risk. And we use a system to gauge how much at risk you are, called the CHADS-VASc score, and what kind of, if you need to be on blood thinners or not. The last thing I'm going to show you, just to make it more sense, is a short video on how AFib causes a stroke, because I think it's so important. I tried really hard to find a great video for you to kind of visualize this, and I borrowed this from our British healthcare system. So enjoy, if you can hear her, the accent as she describes a stroke coming from AFib. If not, just watch and you'll be able to see.
In AF, the heart works less effectively as a pump, with the result that there are areas within the heart where blood flow is slow or stagnant. Where this happens, blood clots can form, and these account for the increased risk of stroke associated with AF. The problem with a blood clot in the heart is that some or all of it can break away and travel along an arterial highway directly into the brain. As the blood vessels branch and become ever finer, at some stage, the clot or fragment of clot is going to be too large to progress any further and will block the vessel in which it is traveling. This means that the surrounding area of the brain can no longer receive oxygen delivered by the blood, causing the nerve cells to stop working and ultimately die. This complication is called a stroke, or more precisely, an ischemic stroke. Because clots that form in the heart may be quite big, they can block wide vessels that supply large areas of the brain. Consequently, strokes arising from AF may often be fatal or can cause temporary or permanent disabilities, depending on how long the oxygen supply to the brain is interrupted and which part of the brain was affected.
So as you can see there, I could just listen to her with her British accent all day. As you can see, it is very important to be aware of stroke symptoms. And Riverside is a stroke center and does amazing things. Now, we just have to get you to come quickly when you see those symptoms, call 911 and present, because there's a lot of therapies and strategies that we can do to keep the disability from stroke from being there or reverse it. So the acronym for that is F.A.S.T. So looking for an uneven smile, looking at your face, an arm, if there's one side that's weaker than the other, speech, listen for slurred speech. And then time is an essence of calling 911 and knowing that you need help right away. And so that kind of leads us to getting ready to have Dr. Alaeddini join us to talk about the strategies for atrial fibrillation and kind of give you a little bit of information about atrial flutter, which is another common rhythm we deal with.
All right. Today we're going to talk about the strategies of treatment for a couple of arrhythmias. One is atrial fibrillation, which is actually the most common arrhythmia. There's also another rhythm which is relatively similar. It's called atrial flutter. And we're going to see what are the differences between these two arrhythmias and what are the treatment options for both atrial flutter and atrial fibrillation.
All right, it's frozen.
The goals of treatment for atrial fibrillation are, the most important one is to prevent clot forming in the heart, which is one of the main reasons for a stroke. We also want to control the heart rate, especially in some patients who have atrial fibrillation and their heart rate speeds up. In some patients, especially those who are symptomatic, one of the main goals also would be to resume the normal rhythm of the heart. As a part of strategy for treatment of this arrhythmia, it's also important to treat the causes of abnormal heart rhythm and its complications, such as heart failure, and also reduce risk factors such as excessive alcohol intake or sleep apnea, which can be treated in some cases with CPAP. So regarding the medication, there are two groups of medication. One is for what we call rate control again. These basically slow down the heart rate and just prevent the heart from speeding up. There's another group which is called rhythm control. These are designed to keep the patient into normal rhythm. As an integral part of treatment of Afib for all of these approaches, blood thinners, which are basically designed to reduce blood clot and reduce risk of a stroke, is also part of treatment with both of these approaches. So the rate control basically, as you see, this is the normal conduction of the heart. Electricity starts from the top and goes to the bottom. In atrial fibrillation, the top is very chaotic, and through this connection, which is called AV node, the heart can speed up to the very fast rates. So the rate control medication, basically they try to slow down the conduction of electricity through this AV node. And by that, slow down the heart rate. There are several of these medications. One group called beta blockers, such as metoprolol, carvedilol, atenolol. Another group is called calcium channel blocker, like diltiazem, verapamil. Also, digoxin is an old medication. We've been using it for decades. In some cases, amiodarone also is used, but for rate control, usually is used for short term. Mostly it's a part of rhythm control approach. Some patients need to be on combination of several of these medications to slow down the heart response. In some cases, even with combination of several of these medications, we might not be able to control the heart rate to a reasonable level. So in those cases, which medical treatment fails, then one of the options is to put a pacemaker. And after the pacemaker is placed, we basically do what is called AV node ablation. Basically, this AV node, we just put a catheter up and burn the AV node. Through that, we basically prevent the electricity of atrial fibrillation traveling down to the heart and speeding up the heart. And then the pacemaker takes over. Because this is relatively permanent in a case after the ablation of AV node, it's reserved for patients who mostly fail other options or they don't have too many options as final approach of controlling the atrial fibrillation. The other approach, as we said, is called rhythm control approach. In this approach, we use medication to keep the heart in the normal rhythm. There are multiple of these medications, flecainide or tambacor, propafenone, ritmol, sotalol, which is also called beta-pace, dofetilide, which is ticasin, amiodarone, donadone, or maltac. Depending on a lot of factors, including the age, history of coronary artery disease, heart failure, and a lot of other issues, the physician basically tries to find the one that is most suitable for the patient to keep the patient into normal rhythm. These medications sometimes only work for a short period of time, a couple of months, but there are cases that you can keep the patient into normal rhythm sometimes for decades. Again, blood thinners are main part of these strategies, both rhythm control and rate control. And if there are patients who cannot take blood thinners, we have this left atrial appendage occluder called Watchman, which can be used. So the rhythm control approach, the medication is designed to keep the patient into normal rhythm. However, a lot of times we need to sort of flip the heart from atrial fibrillation to normal rhythm for these medications to be able to keep the patient into normal rhythm. And that's with a procedure called cardioversion, which is basically through these pads, electricity travels through the heart and resyncs the heart. Most of the time, this is an elective case. For that, patients usually are 3 weeks on blood thinners before the cardioversion, if we have time. But there are times that it might be needed to be done urgently. In those cases, we do a procedure called transesophageal echocardiogram, which basically we put a tube through the esophagus and take pictures to make sure there's no clot. That can be done urgently. There is a newer treatment, which has been going on for last about 15, 20 years, and that is called catheter ablation for atrial fibrillation. There are several different types of strategies. The most common is basically catheter-based, which I'll show you a little bit later. There are also some patients that might benefit from surgical maze or mini maze, which is trying to do the same kind of ablation during the surgery, which could be minimally invasive or open heart. So in these approaches, usually we do, excuse me, ablation around these veins, which are called pulmonary veins. And there are sometimes that we do additional ablations making lines. And there are times that also patients might have both atrial fibrillation and atrial flutter. So in some cases, we do both ablations at the same time for flutter, which is usually on the right side of the heart, versus these ablation lines on the left side. And the concept is to try to electrically isolate these veins and areas that can start the atrial fibrillation. Isolate them electrically from the rest of upper part of the heart, which is called atrium. So there are two main approaches for catheter ablation. One is called radiofrequency ablation, which involves, again, going through this atrial septum to the left side. These are the lesions that we make around the veins. The radio frequency basically causes heat and a small scar around these veins. There is another approach which involves cold or freezing. It's called cryoballoon. Depending on different preferences or patients, we could use either of these, although the catheter-based with the radiofrequency ablation has a much longer record of use, and it's been done more frequently.
During a catheter ablation procedure, a thin, flexible tube, or catheter, is placed through a small incision in the leg, where it's then advanced up through a vein and into the heart. There are two phases during a radiofrequency ablation: mapping and ablation. During mapping, an electrophysiologist creates a three-dimensional image of the heart using specialized catheters in order to identify the area of abnormal electrical signals which may be causing the arrhythmia. In the second phase, ablation, the electrophysiologist directs a catheter to the targeted areas and delivers radiofrequency energy in order to create a small scar within the heart muscle. This will then block the faulty electrical impulses and restore normal electrical pathways in the heart. During a catheter ablation procedure,
Contact force therapy is a minimally invasive procedure that involves the insertion of a catheter through a small incision in the groin, where it is then weaved up to the heart through a blood vessel in the leg. Once the catheter reaches the upper left chamber of the heart, an advanced 3D map guides the controlled application of contact force therapy around the openings of the pulmonary veins. This advanced technology enables doctors, for the first time, to precisely and accurately control how much pressure they're applying against the heart wall to ensure optimal outcomes. The lesions that are created work to isolate and prevent the abnormal electrical signals originating from those pulmonary veins from reaching the rest of the heart. The catheter is then removed, and a small bandage is applied to the area where it was inserted. Patients are typically out of the hospital in 1 or 2 days and can resume normal activities.
There's also a surgical option, as we mentioned, for ablation. of atrial fibrillation. That is usually reserved for patients who undergo heart surgery for other reasons, such as bypass or valve surgery, or sometimes for patients who have had several catheter ablation for atrial fibrillation and continue to have recurrence of atrial fibrillation. So that's one arrhythmia, atrial fibrillation, which is the most common heart rhythm arrhythmia. But there's another arrhythmia called atrial flutter. That's the second most common heart rhythm problem after atrial fibrillation. Some patients have both at the same time. In atrial flutter, the difference is that the electrical signal is more organized and basically goes in a circle in the heart. So the heartbeat usually is much more regular than atrial fibrillation. That's one of the main differences between atrial flutter and atrial fibrillation. The risk factors, symptoms, complication, and treatments are mostly similar with atrial fibrillation, although for catheter ablation, we ablate different places, and the flutter ablation actually has a much higher success rate for cure of arrhythmia, more than 95 to 97%. So, as we said, atrial fibrillation is a reentrant arrhythmia that the circuit basically goes round, mostly on the right side of the heart, more than 90% of time, although it could be in the left side or between the both chambers. The ones that is on the right side is actually called typical atrial flutter. And it involves this area which is called cavo-tricuspid isthmus. As you see, the electricity, basically, this is a section of the right upper part of the heart, and electricity basically circles around and is much more regular than atrial fibrillation. And this is basically an electrocardiogram or EKG of a typical atrial flutter. This is what the boundaries that basically make the cavo-tricuspid isthmus for typical atrial flutter. And so electricity, as we showed, goes around here. So this is the main approach for catheter ablation. We make a line with the lesions, as we showed with the radiofrequency ablation in here most of the time, and that disrupts the electrical circuit. Sometimes we, instead of here, we might do it in a different approach, a little bit more medial, but the concept basically is the same. And most patients will go home next day. And again, this approach has more than 97% chance of complete cure and preventing the recurrence of atrial flutter. Now, Dr. Kaufman is going to talk about other strategies, including anticoagulation for atrial fibrillation.
My discussion today is going to focus on stroke prevention strategies in patients who have atrial fibrillation, identifying those patients at high risk of stroke. We're going to talk about anticoagulation strategies, as well as a non-pharmacologic approach that includes closing the left atrial appendage to prevent strokes. We're also going to touch on a newer type of a pacemaker that is leadless, that may be an option in some patients who have atrial fibrillation. Roughly 6 million people in the United States have atrial fibrillation, and this is expected to double by 2030. If you have atrial fibrillation, You have a high risk of strokes. 1 in 6 strokes occur in these patients. If you do have a stroke, it's twice as likely you'll have a stroke again within 6 months. The strokes related to atrial fibrillation tend to be quite disabling. About 70% of these patients who have strokes results in death or some type of permanent disability. We assess the risk of stroke by looking at something called the CHA2DS2-VASc score. It includes congestive heart failure, hypertension, age, diabetes, prior stroke or embolism, vascular disease. This includes patients who have coronary stents, and female sex. They get a point for that as they're at higher risk after menopause for strokes. Based on the score, you go back to the last slide. Based on the score, you can see that if you have a score of 6 and you're not on any blood thinners or anticoagulants, your stroke risk is about 10% per year. If you take aspirin, which is kind of a minor blood thinner, it minimally reduces your stroke risk down to 7.8%. And then if you are on a blood thinner such as warfarin or Coumadin, your risk is in the range of 3.4%. We also assess risk of blood thinners by looking at the bleeding risk with Coumadin. And patients that have hypertension, abnormal kidney, liver function, prior stroke, bleeding issues, labile INRs, difficult to regulate, and the elderly, as well as people who drink alcohol or on current medicines, they have higher risks of bleeding. If you have a score of 5 or more, your yearly major bleeding risk can be upwards of 12-13%. So it's important that we kind of balance the risk of the blood thinners versus the risk of stroke. When we talk about blood thinners to prevent strokes for Afib, we're typically talking about medicines such as Coumadin or warfarin, or the newer medicines called the direct oral anticoagulants, and we'll talk more about those shortly. This is an image of a transesophageal echocardiogram. Transesophageal echocardiogram, and what we're looking at here is a left atrial appendage, and you can see this area in here that represents a blood clot or a thrombus formation. So this patient is certainly at high risk of stroke, and 90-95% of the clots that cause strokes in Afib tend to form in this left atrial appendage. So the anticoagulants we're looking at are Coumadin and the direct oral anticoagulants, which include Eliquis, Pradaxa, Xarelto, or Savasa. We also are going to talk about a left atrial closure device that we're performing called a Watchman implant. Warfarin or Coumadin is the most studied, been around for a very long time. It can be reversed with vitamin K agents, and it's least expensive. The risks of it, the effectiveness or INR can fluctuate depending on your diet. Some medicines can interfere with warfarin or Coumadin. It does require somewhat frequent blood testing to make sure your blood is not too thick or too thin. And patients often are not in the target range on this medicine. The therapeutic range for the INR tends to be between 2 and 3, as it's recommended. Sometimes when people fall below this number, they can be at risk of clots or strokes. Certainly if they get above 3, they can be at risk of major bleeding events. Pradaxa is a direct thrombin inhibitor. It was the first direct oral anticoagulant to get approved through the FDA. It's easier to take than warfarin. It doesn't require any blood tests. There are no diet restrictions. There is a reversal drug, but very expensive, may not be readily available. These patients can certainly have higher risks of bleeding, especially in the GI tract. Factor Xa inhibitors, Xarelto and Eliquis, doesn't really matter how these medicines work to prevent clots as far as the mechanism, but they've been well studied and they all work well. But there is the risk of bleeding. They don't require blood tests. They do tend to have a lower risk of bleeding into the brain compared to Coumadin. The other issue I want to mention about them is the cost. That tends to be a factor because they are quite expensive, and not all insurance companies will help pay that cost. We can see that over time, even with the use of all these oral anticoagulants to prevent stroke, only about 50% of patients are taking them. And even with the direct oral anticoagulants, maybe 60% of patients are on anticoagulants. There's approximately 40% that aren't on these medicines. Either they don't want to take Coumadin because somebody's bled on it or died, and the direct oral anticoagulants tend to be quite expensive. So you can see the challenges that we have. Warfarin, there's bleeding risk, sometimes difficult to regulate the INR. There's medication interactions that can occur, issues with stopping it for surgical procedures. The direct oral anticoagulants do have bleeding risk. It's limited, I think, a lot by the cost. 83% of patients with Afib would be willing to try a different treatment to help reduce their risk of stroke. So we do have an option of a non-pharmacologic mechanism to prevent strokes, and that's this Watchman device. This is an image of a Watchman device sitting in the left atrial appendage here. This is a one-time procedure that may reduce the stroke risk for a lifetime. It's as effective as taking blood thinners such as Coumadin. It reduces long-term risk of bleeding. The indications are patients who are at increased risk of stroke or embolization based on a CHADS VAS score of greater than or equal to 3, and they are recommended to remain on anticoagulation therapy. They have to be deemed by their physician to be suitable for short-term anticoagulants, roughly about 6 weeks till the device heals in and endothelializes. And patients have to have an appropriate rationale to seek a non-pharmacologic alternative to warfarin or Coumadin. And these are some of the factors that are involved in seeking a non-pharmacologic approach. Patients who have bleeding or increased bleeding risk, patients at risk of falls, documented poor compliance with oral anticoagulation therapy, inability to maintain a therapeutic range or INR, increased bleeding risk not reflected by the Hazlitt score, such as low platelet count. Certain occupations put people at high risk. Issues such as triple therapy, which is taking aspirin and Plavix after a stent procedure, and then starting anticoagulants. Those people are at higher risk of bleeding because they're on multiple blood thinners. So it shouldn't be that patients just don't want to take the oral anticoagulants. They generally have to have a reasonable reason why they want to get off them. This is the clinical timeline of the Watchman device. It was initially looked at in 2002, became FDA approved in 2015, and a lot of studies involved over 6,000 patients. This is what the Watchman device looks like. This was the original generation Watchman. You can see it has these kind of barbs at the distal end. The newer device is called the Watchman Flex. much more atraumatic at its distal end. And I think that's the main advantage of this newer device. It has more pushability, whereas this one, you had no ability to really advance it forward into the appendage. Some more images of the first device, and this is the now the Flex device. That's the main thing. I think it's quite a bit safer for implantation purposes now. Very safe. Ischemic strokes are in the range of 0.5%. In the Flex data, there were no deaths, pericardial effusions requiring surgery, or device embolizations. The sizes are now give us more range. We now have a 20 millimeter device and as large as a 35 millimeter device, depending on the anatomy of the left atrial appendage. It's important to note that not all appendages are the same. They're quite variable. So this is a procedure that does not require open heart surgery. It's done under general anesthesia, usually takes about an hour, typically one night stay in the hospital. So it's inserted through an access site, usually in the right femoral vein in the crease of the groin. We go up to the heart, go over to the left atrium, and kind of deploy this device here in the appendage.
Introducing Watchman Flex, built on the most studied and most implanted LAAC device in the world. Watchman Flex is designed to advance procedural performance and safety while expanding the treatable patient population. Watchman Flex has full recapture, reposition, and redeploy capabilities for precise placement. It is designed to have a quicker complete seal for the best long-term outcomes and to treat the widest range of patient anatomies. Watchman Flex is available in 5 device sizes with an allowable compression range of 10 to 30%. Watchman Flex pushes forward as the leader in LAAC therapy. To perform the implant, the physician accesses the patient's femoral vein and, using a standard transeptal access system with a puncture needle, crosses the septum to reach the left side of the heart. Watchman Flex is designed for precise placement in the left atrial appendage. From windsock to broccoli to chicken wing. Measurements are taken of the appendage with TEE. Contrast may be injected at any time to help visualize the left atrial appendage. At this point, the appropriate size Watchman Flex is selected. The Watchman Flex ball is formed. The fully rounded ball is designed to safely advance and maneuver within the left atrial appendage. Watchman Flex has full recapture, reposition, and redeploy capabilities for precise placement. Before final release of the device, the physician checks the pass criteria. Position: the device is flush against the ostial plane. Anchor: the fixation anchors are engaged and the device is stable as proven by a tug test. Size: the device is compressed to 10 to 30% of its original size. And seal: using color Doppler imaging, the physician checks for residual flow around the device. Dual-row precision anchors designed to provide optimal device engagement with LAA tissue for long-term stability. Reduced metal exposure and long PET fabric designed to reduce healing time and reduce thrombus formation. Once in place, the device endothelializes to seal off the patient's left atrial appendage. Post-procedure, the patient takes an oral anticoagulant and aspirin for at least 45 days until a complete seal is confirmed by TEE. After discontinuing the oral anticoagulant, the patient takes clopidogrel and aspirin followed by ongoing aspirin therapy. Built on the most studied and most implanted LAAC device in the world, Watchman Flex is designed to advance procedural performance and safety while expanding the treatable patient population, pushing forward as the leader in LAAC therapy. Watchman Flex.
We talked about after implant, anticoagulation and aspirin for 6 weeks, then clopidogrel or Plavix and aspirin for 6 months, and then aspirin daily thereafter. This is what the device looks like shortly after implant in the appendage. And this is when it endothelializes and forms tissue over it and is all healed up. Procedure implant success rate above 98%, and 96% of patients can get off anticoagulation at 6 weeks. So we're going to switch gears here and just talk a little bit about a new type of pacemaker that is leadless, made by the Medtronic company. You can see it's about the size of a nickel. It gets the standard pacemakers involve generators that are up in the chest. There are transvenous leads that go through the veins into the heart. Leads have issues where they can break, they can get infection. Sometimes they need to be extracted. This leadless pacemaker is a tiny device that gets deposited right into the right ventricle. So they have no external signs in their chest of any leads or generators up here, but it does show up on the chest x-ray. Compared to a transvenous system, quite a bit smaller. Works pretty much the same way. It is MRI conditional. Battery life is about 12 years. The advantage to this leadless pacemaker, useful in patients with recurrent infections of transvenous systems. These leadless ones tend to have a very low risk of infection. Might be the small size, might be the blood flow in the right ventricle, might be that it's not touched by anybody's hands prior to deploying in the right ventricle. So, but overall, much lower infection rate. I think there's only been one report of an infection in one of those devices, and there's been over 100,000 implants done.
Thank you so much, Dr. Kaufman, Dr. Alaeddini, and Kim. Thank you for taking your time to pull all of this great information together for us. While an Afib diagnosis can be overwhelming, it is really reassuring to know that there are so many treatments out there and different approaches that patients can take. I hope everyone has enjoyed the presentation, and I hope you will join us again next Thursday, when our Heart Month lecture series will focus on vascular health. Until then, thank you again for watching, and I hope you have a great evening. Good night.